PowerPoint? Shall I wait? Okay. Well, while we're doing this, I'm a psychiatrist, and so I'm going to take you on a tour that's a little bit different than what the other good folks up here have presented to you. And the reason that they're having a little technical problem is because it took me about 2 weeks to find the slide that I wanted to end this presentation, and I found it, and so they're going to try to load it. We wait. If they can't load it for whatever reason, we can use the old one, and you'll see the spelling errors too. How long shall I wait?
You can go ahead and use the old one.
Yeah. And I will tell you, so let me preface it a little bit. I put this together. This is 10 minutes of time that really requires a couple hours to look at it from a psychiatric point of view. So I put in many more slides than we could ever look at in great detail, but it will be available on the website. And so I would encourage you to please look at that. One of the things that we're looking at here while we're waiting for the pictures to show up is that psychiatry is different. Psychiatry is not general medicine. We're not looking at pain. We're not looking at spasticity, multiple sclerosis. We're looking at other issues. And most psychiatrists, I would say 99% of them are against medical marijuana in the way it's being proposed. I like to put it that I am not against the molecule, I am just against the way it's being used. And this is a very, very serious problem. When the slides come up, I'll show you that there is a number that continues to pop up, that roughly 9% of everyone who uses marijuana is, there we go, cool, okay. Which button here? The green. Okay, so again, more questions that we can answer. Do we really have enough reproducible research? The answer is no, and we look at it very carefully in terms of properly powered studies, in terms of effect size. We do not have it. It doesn't satisfy psychiatric things. And the question, again, that has to be asked continuously is, why are so many psychiatry and addictionology people against it? There has to be a reason for it, and the reason will be touched on as we go through this. The questions are, of course, in terms of legislator, are we looking at decriminalization or the medicalization? And I think we're getting confused, and some people think that medicalization is the same as decriminalization. It is not. They are two completely different animals. Now, one of the things that also bothers us is that there's no MedWatch for medical marijuana, to my knowledge, anywhere in the United States. So if someone has a bad effect to one of our drugs, it gets reported eventually to the FDA, and if it happens frequently enough, then they issue some sort of warning, they take it off the market, they study it, or whatever. We're calling it medical marijuana, but we don't have this built in. And of course, it was interesting, I was in a meeting last week, and I was a whole bunch of really good psychiatrists, and I said, does anybody here know how to dose marijuana? You know? No. And so, as was mentioned before, the question is, who is actually going to do the dosing? The dosing is going to be by a guy at a dispensary, and we don't know how much training or whatever that he has. Now, one of the things that's often the issue is that marijuana does not cause emergency room visits. This is a report from SAMHSA, and it shows that the highest number is from cocaine. I hope it's in focus. The second highest number is marijuana, but if you look carefully, the dark blue are people under 20, the lighter blue is people over 20, which shows that a very disproportionate number of people who use marijuana under the age of 20 end up in the emergency rooms for various reasons. And we do have to say that part of the problem with this is that it's the It's the efficiency and the ability of the ER people to do proper diagnoses. That is an issue that the Dawn system has for a very long time. But forget the specific numbers, just look at the slopes. The slopes are rather concerning. Now, we said that 9%, and this is a number that keeps popping up, and we seem to be ignoring the 9% in order to the 91%. And you'll hear the arguments, well, alcohol's this and tobacco's that and so on and so on. The answer is yes, that is true, but we shouldn't forget that the 9% who become addicted are really exposed to a future of great problems. And again, most psychiatrists have seen this more than once. Where are we here? Okay, the question is it a gateway drug? Psychiatrists will say yes. 9% of the population become addicted. It is certainly a gateway. Are we going to say that gateway doesn't apply to anybody who is in the 91%? Well, the variabilities are so great. What we do know is that when they start, we have a 9% chance of it getting worse and worse and worse. There's an old term from the old days, most of you may or may not remember it, it's called chipping, and that's when people would use heroin on the weekend, just on the weekend. They never got addicted, they went to work. That was all well and good. So the question is, are we going to deny the 91% the opportunity to do chipping and just throw the 9% out? And then if we do not throw the 9% out, how do we screen for them? How do we actually identify them before we recommend that they be allowed to go use medical marijuana? Okay, so one of the things that's very interesting, and the question has come up several times, and it's a struggle that we have all the time. What does marijuana do? And what we now know is that marijuana causes a release of dopamine in the brain, so you feel good for a while. But what happens is that after prolonged use, the ability to respond to that dopamine diminishes, and it takes more and more to get the same effect. Now, the other thing is that marijuana has an extremely long half-life in the body. It loves the liver, it loves the fat, and it can be very confusing to someone who uses it on a regular basis. But we do know that the propensity to get into this cycle where you need more and more to achieve the same high is because you're pushing the dopamine system, and the dopamine system then effectively becomes non-reactive to the marijuana, and you go into a very nasty cycle. And if you want to call this addiction, there are definitions of addiction, but this is what leads to a lot of the problems. Okay, and again, it's basically saying the same thing. There's more information here that we'll touch in 10 minutes. So we have seen that long-term marijuana use is associated with striatal dopamine synthesis reduction. That is not an if anymore. That we know, and if we're going to prescribe it, we have to be aware that there are potential long-term side effects. Okay? Now, what's interesting, towards the end, you'll see another slide, that the apathy that sometimes occurs with marijuana is because the dopamine system has become non-functional. And if you've ever treated cocaine or methamphetamine users or whatever, when their dopamine coops out, they go for more and more and more, and when they don't have it, they become apathetic, and then they end up in emergency rooms and God knows where, because they're trying to restore a normal dopamine system, and it just is not working, and particularly in the 9%. Q elicited, this is a really interesting psychiatric problem. If you take someone who has an addiction and you expose them to something that reminds them of the addiction will come back. When I used to treat a lot more cocaine users, they would come to my office, and we would really go to the trouble of them not driving the same road, so they wouldn't drive past the place where they bought the cocaine. And another thing that has to do with addiction is that we used to give, for heroin addicts, stainless steel staples, put them into their arm. And whenever they got the need for a hit, they do that so they would feel something breaking the skin. So the question is, what are they addicted to? Are they addicted to the sense of something breaking the skin, or are they addicted to the dopamine and other chemical changes from the use of the drug? So, okay, but again, I remember how good it felt, and seeing the Q makes it more difficult to resist. One of the things that's absolutely so critical when we're trying to treat someone with an addiction is to get them away from their old friends. You have to do that, because otherwise they're all going to relapse. I shouldn't say all going to relapse, that's a bit much, but many times they truly relapse. Okay, so more about the dopamine system, which we'll look at another time. There was a drug produced by Sanofi that was hopefully anti-marijuana. It was an effort to reverse the activities as anti-munchies. They called it, they hoped it would be a diet pill. It backfired. It was withdrawn. Very much a great idea. Made a lot of sense. Didn't work. So it was completely taken off the market. There has been a suggestion that schizophrenia results from hyperactivity of the endocannabinoid system. Very interesting idea. The answer is maybe, but we're about many, 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 many years from being able to say if that's true or not. But the question is, if there is a predisposition in somebody and we give them medical marijuana, and this is not screened, we could potentially induce a psychosis. And therein lies the problem. So the doctor who writes the prescription for the marijuana, excuse me, not prescription, writes the recommendation for the marijuana, if they haven't done proper work or follow-up, or as one of the gentlemen here said, they don't know how many people, what the doses of what they're taking, you could induce a psychosis. Okay, just the animals. But what's really interesting from, if you remember back to biochemistry, the molecules look pretty much the same. Now, there are differences, and we all know that you add a chlorine atom here, a fluoride atom there, you can have a very different molecule. Very different. We know that. But if you look at Tegretol and you look at the antidepressants, the tricyclic structure is the same. And so they can interact. So we do not have adequate amounts of scientific data to know that this will or will not interact with any medication that someone is taking. We don't have it. That data does not exist. Okay, some history. Well, when it was invented or discovered, when it was invented, when God made it, it was discovered in 1990, 92, the CB1, CB2. CB1 tends to be in the brain, CB2 tends to be external. And now I'm going to get into some interesting stuff because this is going to be kind of hard to read. This is from a nursing journal, and if you look at the bottom, it talks about how therapeutic, I can't read here, relationships between individuals and their health providers is, I can't read it, but it says that it shouldn't be blocked by prohibition of cannabis if they want to use cannabis. And we saw a lot of these. But here's an interesting question. Okay, so let's say you recommend marijuana. Are you recommending on-label or off-label? Big thing in our business, right? There's no label. So how do we define it? How do we put it together? We can't. It scares the bejeebies out of psychiatrists. Okay, now, this is when the young lady in New York, they passed the Charlotte's Web, this is in July? And all the politicians are around there, and I suspect that the woman is her mother. And when you look at this cute little girl, who's going to say no? My God, this poor little child. She died. And I don't know what it was, because obviously they're not going to make that too public, or they haven't thus far, but the suggestion came out that the reason she died is she did not have access to the cannabis product fast enough. And that has been to fuel the anger against those of us who oppose marijuana or the government. And again, all of us, I'm sure, there's not one of us who doesn't want to get something that can help people get better. That's not the issue. That's really not the issue. Okay, part of the problem is the believability issue. We deal with this all the time. Why do people not believe that we have these concerns with marijuana? Well, part of it is their own arrogance. I spoke to a lady this morning, and we were talking about it coming here this afternoon. She says, "Oh, it's not dangerous. I smoked, and I knew lots of people." I said, "Really? Did you know everybody?" Come on. And they like to take these little bits and pieces. They like to take their opinions and change them into facts. And why a little editorial asterisk is that's what the politicians are doing. Okay, now, we're going to go here for a second. This is an ad, and if you can read it, it says, "It is believed that the endocannabinoid system is the regulatory system for all other biological systems." All. That's kind of cool. And, thus far, there doesn't seem to have been that product from any pharmaceutical company, any academic research department, anything to support that. But this is what the pro-marijuana people are reading and hanging their hats on. Okay, now, if you look at it I'm going to show you something in Google searches, how much people are actually looking for it. But in September 2013, University of San Francisco gave people CME credits to make sure that Wikipedia is correct. Because they go to Wikipedia and they read this stuff up, and it's not always correct. Wikipedia is pretty good, but not bad. Okay, that's it took a long time to get that. That's Wikipedia's search reports for medical marijuana over 90 days. I do not understand why it peaked up, down, up, down, up, down. I need to look at it and break it up to see if it has to do with weekends or party nights or whatever. But isn't it intriguing how there's that regular pattern to it? And I don't know why. Okay, so more day-to-day questions. One of the things that we've talked about amongst ourselves is in Florida, if it is passed, will it be put on the database so that I can punch in and say, oh, you're on medical marijuana, because a lot of people don't tell the truth. And then the reflection from that will be, well, you know what, you're on marijuana, you got it from another doctor, I'm treating you with psychotropic medications, I'm really uncomfortable treating you, I'm not going to treat you. And there's a very strong potential for a lot of psychiatrists to no longer be treating people who are on medical marijuana because we're treating with, like I was going to say one eye closed, sometimes two eyes closed. And if the state of Florida doesn't address this, well, you can fill in the blanks. We can't deal with that. Should there be a triplicate form? What's our reciprocity with other states? I wrote the Attorney General, Pam Bondi. I got back a letter that was not really, shall I say, informative. And she just said, don't do it. Whatever. Okay? Now, and again, this is the question that applies to all of us, and why, you know, these little intricacies of metabolism and all those sort of things, right? That we're mixing psychoactive drugs with all sorts of other metabolic phenomena. You know, who's measuring it? Who's following it? And this just has to do with, when you go into psychiatry, there are different groups of whether or not people use medications to escape life or they use medications to join life. So sometimes we put people on a lot of concoctions, but you know what? They're going to work. They're functioning. They're using the medications to join life. A lot of times they take the medications to go home and get stoned or inebriated, then they're using the medications to escape from life. A very simple difference, and they're not being adequately monitored in the current areas in which medical marijuana is being used. To me, it's not medical. Okay, just additional groups. Now, I'm always, this is the part that I'm concerned, this is probably the only part of this whole talk you're going to remember. Okay, because of the pictures. Okay? There's a journal called the Journal for Education of Medical Marijuana. It's very, very popular in Los Angeles. I went into a dispensary out there just for the heck of it. My brother told me don't get in trouble. And I picked up one of their journals. And these are ads from May 2014. Some of the ones that I have from earlier were too close to soft pornography to bring here. Okay? This is one of their ads. It looks like it fixes everything. Okay? I mean, this is what people are reading. And this is what they believe. Okay? Now, this is from Colorado. These particular ones. These are the edibles. That's their inventory. And, you know, it looks very nice and so on and so on. Some of the problems they're having right now in San Francisco is the dogs are eating this, and the dogs are getting sick, and getting very, very sick. And they're having problems with that. Okay. I have to go over, I don't know if you can read it from here, but these are the different candies and stuff that you can buy in Colorado. And if you see here, the bulleted line, the second one, available in 10 milligram and 25 milligram for recreational use and 50 milligrams for medicinal use. So to me, that means 2 milligrams or 5 milligrams of Valium is to get high, but 10 milligrams is medicinal. It's the same stuff. Where else does medicine do that? Okay, let's quickly go down the list here. This is another one. These are for chronic pain. 50 milligrams of ultra-concentrated THC available in Colorado and in a lot of California and other states. We are so afraid of this happening in Florida. This is a huge concern because this is entrepreneurial. Okay. This is the journal. It's not a real journal, but they call it a journal. Okay. Again, the next pictures, I know the ones you're going to remember. Okay, that's the advertisement to go into a doctor to get medical marijuana. $35 to come in, $25 to repeat. They have an ATM machine there if you need it. And, I mean, really, if you ever have an opportunity to go into one of these, you should. You really should. Okay. Now, where does this come off being attached to medical marijuana?
Sign me up.
But this is the entrepreneurial aspect of what's going on. And for a lot of our patients who may have very soft